Today's episode of the Gestalt Education Show is brought to you by three of our favorite sponsors: Human Locomotion, Core 360 Belt, and Dynamic Disc Designs. All the information can be found below. By now, you have definitely heard us talk about them, so check out the show notes, click the links, use the codes, and make sure you support our favorite people. As always, we got a great episode lined up for you today, and thanks for tuning in. All right, everyone, welcome to another episode of the Gestalt Education Show. Today we are here at Parker University, Parker Fit, right after the Rehab to Performance Symposium. Brett, you just got done teaching. It was all on the upper extremity, so it was really good. Yourself, Jason Holm, and then Andrew Hauser kind of gave in different aspects. It was honestly great because all three of you practice very differently.
Yeah, that's true.
Very differently, right. And so it was really cool to kind of see the different perspectives. There's a lot of amazing people in the crowd, such as the person that we're sitting down with today, and so we've been meaning to get to the.
Flirting.
I know. We have not been to the West Coast in so long.
Well, we were always wanting to partner up so we could drink some Pinot and some Chard.
That's right.
In Oregon.
So which is going to happen.
Yeah,
that's definitely going to happen. But anyway, so today we are sitting down with Dr. Phillip Snell, and Phil, I know you from Fix Your Own Back. I know you from social media and some things like that. I haven't got the pleasure of formally introducing myself and meeting you until this weekend, which has been fantastic. But you're a pioneer in our profession, someone that we look up to, especially when it comes to, I think, empowering patients and empowering the people around us and getting that message out there. And beforehand, we were kind of talking about Stuart McGill, and I think both of you cut your teeth on Stuart McGill, and I know that has been a huge influence. And getting to hear stories from you two about Stuart McGill and your influence has been just really special. So I'm sure we'll talk about that. But Brett, do you want to kind of kick it off? Like, how did you first meet him and your relationship since then?
I think probably like early on in some DNS courses, probably, back when, both him and I were probably taking these courses. And then it really, in our world, I think it's just a small world, and then Phil, you kind of went down the R2P track. And I mean, I haven't like directly been associated with them, but always kind of on the outside. And we all have it's a small world. So I think like we've just, been in contact, and I would say that's similar goals. I think we're both, I would say we're integrators, we're kind of one of our big crusades is teaching people how to like take different systems and be able to mix and match for the best clinical outcome. I think that's kind of like the parallels that we probably had throughout our career, probably.
Love it. Well, let's kind of, I me personally, I'd love to kind of break down Fix Your Own Back and where that started, where you felt that the hole maybe was in the industry that was filling at the time, or like what prompted you to kind of create this system or this coursework. I don't know what's the best way to describe it. That'd be for you.
There were a few inputs on that. Probably the shortest answer, though, is Stu kind of asked me to do that. I had a program for a number of years called My Rehab Exercise that was a repository of corrective exercise videos that I put together that I sold to memberships to for other doctors to be able to use to send exercises to their patients. And as the promo for that site, I interviewed Stu, and I had known Stu because he helped me get out of the weeds when I herniated a disc in my back in my first year of practice 21 years ago. So I had gotten to know Stu a little bit through that, and in the conversation before we went on, he mentioned that he needed folks that knew the literature relatively well at that particular point in time. He was suffering from the slings and arrows of outrageous misfortune out there. Read social media was ripping him a new one, unjustifiably so, and he was basically asking for an assist from other people that had some awareness of what the literature says to stand up and talk about it in a social media kind of an environment and an online kind of an environment. And that was part of what did it. The other thing that did it was I felt like one day in practice, like I was a Catskills comedian on the third or fourth show of the day. I had, this would have been around the time that Google bought YouTube. And I was seeing an uptick in patients with back injuries after implementing exercises that they had learned from trainers on YouTube. And I was like, somebody's got to wade into this that understands this a little bit better and speak with some level of authority on it. And those two things, talking with Stu about that and that phenomena, is what put me on the path to make that. The third show of the day reference from the Catskills Comedian, I literally had 3 back pain patients with disc herniations at the same point in their rehab back to back. And I was prescribing Stu's McGill's Big 3 to each of them. And to each one of them, as I went from patient encounter to patient encounter, I was refining and, tilting my delivery of that information just a wee bit different to individualize it. And, I was, at some point there, I was like, I ought to just film this and, make it available that way, and then we can do other things. So I went home and I figured out how to build a website. And I built a website and I called it Fix Your Own Back. And Fix Your Own Back in its first iteration was McGill's Big 3. And it was only for my patients. And my patients used it, they loved it. And then I started to get a few emails. And these emails were from mostly other chiropractors. And they were like, hey, saw the site, really love it. What do our patients do next? And I'm like, wait a minute, I made that site for my page. This is well before you could figure out how to keep certain people off of your site. And he said, well, why don't you maybe make a few extra videos on what our patients should do next and charge us something for it? And I'm like, all right. And that's what my rehab became. And then later, when Stu said what he said, I'm like, well, maybe I ought to go back and put all of that together into a rubric or heuristic that makes sense for a person in the general public when they need help to get over the hump on and to sort through the complexities of a disc herniation in the low back. So.
Beautiful. What do you think? What were the commonalities that you were seeing in those patients? I know that you were kind of changing your message a little bit depending on what the case was in front of you, but what are some of the commonalities that we're seeing that are maybe predisposing our patients, one, to disc herniations, and then maybe those things that are blocking them from getting over that hump to really getting back to the things that they were trying to get back to?
The thing that I had this question, I batted this back and forth several times with both Stu and Craig Levinson, whom I helped with his coursework for a number of years as well. And, the buzz, as you've seen on the shirts from, much of this weekend, is N equals 1. And we all know that that's true. But if you look at it from a public health standpoint or an epidemiological standpoint, if we only always leaned on N equals 1, we would really not advance the science beyond maybe an RCT. You don't get a systematic review or meta-analysis out of N equals 1. You look for enough common variables in a situation or a presentation that you can make a relatively general statement about a population. Sure. And what I was seeing was that there were a whole lot of people that were basically initiating movement towards the floor in a poor manner. And they were initiating that movement out of a part of their spine that human beings, from an evolutionary perspective, are relatively vulnerable in. And that causes an overuse issue that results in one of the more debilitating conditions that I had personal experience with. And it's like, all right, well, I suspect that this is something that if we were to just address some very basic issues, load management, stabilization strategies, lifestyle, even diet, then we can probably take, instead of an N equals 1, let's take the N equals 1 from 100% of the population down to a 30%, because I bet if I just made almost a template and said, if your back hurts in this particular way, do this. Does it make you feel better? Read McKenzie directional preference. Okay, if it does, boom, let's then do this. Read Stu McGill. Let's do some basic high threshold stabilization strategies. If so, then yes, now let's refine. Let's move to a DNS kind of foundational low threshold strategy. And now let's look at leveraging that for the rest of your life into better quality movement, and then load that son of a bitch and make it stronger over time, and then go do more of that. And that's what I tried to do with the program. And you know, it's helped some people, but
I think it's helped more than some people, so that's for sure. What about the second half of that? Like what, I think this is a common thing that happens in chiropractic practices, PT, things like that. You get an initial reduction in pain, but then the function is the thing that we have a hard time to finish off, or like to actually change the function so that maybe we do get some prevention long term, or maybe we do get some of those strategies to deal with the symptoms if they were to come back. So what are some of those things that hold people back from getting to that next kind of standpoint?
You know, that in my world is where that N of 1 comes in, because I don't think you can shortcut that.
Yeah.
I mean, that's the beauty of DNS, and that's what you're doing as you learn and mature into that system, and you develop the eyes, the hands, the pattern awareness of being able to work with the individual that's in front of you, and to tailor that program for that N of 1. So I'm not sure that we can stand back and hold at arm's length and say, yeah, I think you probably need a low oblique sitting position. Let's just work you through that for a period of time. I don't think you can do that so well. That's where, blessedly, probably we all are still going to be in demand in the general public and in public health in general, right. To have that expertise in the N of 1.
Right. And I think too, I mean, we're learning about low back pain is basically, it's kind of like a common cold. Like you still got another bad day ahead of you probably, and you could have back trouble down the road, So like this whole idea of fixing things, I think sometimes is the wrong mindset, because just like if you were to, come down with like a heart problem or something like that in the cardiology department, like you're going to get managed. Or if you have a metabolic problem, like someone's going to help manage your thing. And I think sometimes we make a mistake sometimes of thinking like that, you have back pain, now you're fixed, go live your life. Like back pain is way more complicated than that. And so like it requires a different approach where, you're going to have peaks and valleys, and we just need a positive slope of improvement as you're moving along. And I think like that's a message that resonates well with a lot of people, because once they have that next episode, then they feel like, well, shit, this isn't working. And it's like, oh, you're going to, so your back hurt again. So we can bring you back out of that. These are the approaches. And I think you've done a really good job of arming the patient of like, when you are in that moment, take a couple days and try these techniques. And you'll probably find that a lot of times you're going to pull yourself out of that even on your own. If not, then you're there to help them potentially. And, we're there to be a coach in your life to kind of guide that. Yeah.
And one of the first things in working with the patient, once you've got a reasonable idea about what's going on with them, we all know is to set reasonable expectations. And that's not to say, I would say that is actually fixing a back. That where are you going to be back to factory specs? Probably not. Your collagen, the type 2 collagen that you're going to use to reform that, the changes in the biomechanics at the cellular level, at the tissue level, and at the gross level of function, all of those are going to be different after an injury. But there's not really that much difference than there is after a knee injury, or after an ankle injury, or after a shoulder injury. We were here this weekend primarily with you guys talking about shoulder stuff. And, I've got an unstable shoulder that's likely a surgical candidate right now. And I've been banging around on this thing for 15 years after a couple of, really nasty injuries. And I can look at it from one way to say that I haven't fixed my shoulder. But I've managed my shoulder quite handily for 15 years and been quite physically active during that period of time and have been able to do all the things that I wanted to do with it. Now I can't. Right. Because I've got a joint blocking issue. Right. And I've tried to shrink that sucker through, thick and thin, and now it's at a point where, I can no longer load up on a patient in side posture without really significant pain and a clunk.
Right.
So now it's time to go to our colleagues.
Yeah, that's right. Well, I think that's a hard part too. I think medicine always it's run through the orthopedic lens, and so it's very easy for you to go to a surgeon. They look at your shoulder and say, "Boom, this is what you need. This is the surgery. You're fixed now." And so we try to kind of blend that over, and that, like you said, it's just not the reality. Things
you got to live a
change.
life.
Yeah.
And living a life means, as you point, it's ups and downs. Right. So set reasonable expectations and don't catastrophize when it happens.
I think too,
Self-soothe.
Yeah.
Lay in your crib and cry.
Yeah, exactly. Well, the way that I love the way that it's actually phrased is you have copers and you have non-copers, in the world of chronic pain, you have people that, they understand what you're talking about here. And then you have people that, have the exact same injury, but because of autoimmunity or because of maybe, unfortunately, abuse or whatever the example is, they're in the non-coper category. So those non-copers, we need to be there to help them through their moments. That could be change of diet. That could be getting them excited about exercise, getting them the appropriate therapist. But I think the thing I wasn't good at was I was not so good at buying in this centrally mediated pain as I needed to be. And then the more complicated cases I saw, I'm like, okay, I need to surround myself with an Annie O'Connor or a Lorimer Mosley or David Butler. Cause I was not appropriately appreciating that centrally mediated, smudged pain presentation the way that I needed to be. Because in my mind, I'm like, you're fine. You're going to be okay. And then when I finally realized that, I understood that these people, what they're feeling is actually real pain in their mind. It's not that they're not tough and things like that. And I think that's an important point,
I think it's huge. Like you, like all of us, I think the literature before it was very apparent. You and I were taught as clinicians way on to see those patients with those types of presentations in a suspect manner. I mean, if that was a med legal case, they were a malingerer in all likelihood. If they were someone that needed to be in someone else's office, and perhaps they do, because I would be probably one of the first to say that chiropractors and physical therapists are lousy pain psychologists.
Right.
I live not a pain psychologist, but I live with a psychologist, a tenured professor in that, and I know what she went through to learn the things that she learned. And you ain't going to get it from a weekend course, chiros, by taking a pain neuroscience course and reading a damn book.
Right.
And to my mind, those are the areas where we do a hell of a lot better by being really, really good at what we do, what we're taught, and then get better about knowing what the others in your community know, and then refer appropriately and work with everybody else on that. And then the point I would put on that is something that I put a slide together for one of our for the Fix Your Own Back course after a conversation that I had with my son, and we're both kind of foodies. And he is now in med school, but this was well before any of that, and he used to like me to share shop conversations to kind of, get his critical thinking together. And we were talking about pain neuroscience one day. And after I finished talking about it, he came up with the analogy. He said, it sounds kind of like talking about salt in food. I'm like, what? He said, yeah, basically it's not about what kind of salt. Now, you can argue that in Portland, right?
Sure.
But it's not about the kind of salt you use. If you're cooking a dish, it's more about how much you use and how much you didn't use. Bottom line is you shouldn't be talking a whole lot about salt in your food unless it's a hell of a lot of salt, and then you should probably maybe dilute that. Mm-hmm. If there's not enough salt, then there's a reason for that. You got a little shaker on the table, and you put a little bit of salt, and you make that good. Well, that's your clinical encounter. You shouldn't be talking about pain neuroscience as a chiropractor or a physical therapist that much with your patients.
Right.
If you are, you're going to have a whole lot of patients that give you the same look that we've all had from those patients. Of what you're saying, it's all in my head?
Right.
Yeah, you can work on delivering a message in different ways, but it's more often than not going to come out like that. Mm-hmm. So what do? Well, you think in a way with that patient that you, or deliver a message in a way that they can hear it, that's constructive, mm-hmm. and then you refer appropriately. And in the meantime, you try to just nudge them towards movement and towards things that you've learned in your history and examination that will allow them to prove to themselves that they can help themselves better.
Right. Well, I think too, it comes for me personally. I agree. I'm not very good at the pain neuroscience. I admit that, but I think part of being a good clinician and a good healer is having some empathy in those situations and understanding the classification. I think that there's a lot of people that do need that referral that we probably under-refer, frankly.
Sure.
But I think a lot of people will get better and feel part of like the healthcare team and get more confidence in their healing journey with empathy and with someone that's a coach or with someone that's giving them the space to actually like work through those things, which I think is an understated thing that we talk about. So
I think too, like in our world, like you and I were kind of taught originally, like if they score high on the yellow flag form, like it's a hands-off approach. Like at that point, like you do not put your hands on the patient. Well then, and I did that for the first 10 years of my career. Well, then the research start pouring out in the low back where like actually chronic low back pain actually responds to like a modality like manipulation. I'm like, maybe we need to rethink this. Like maybe that doesn't mean you can't put your hands on them. It just means like we need to, we're going to handle them a little bit differently. But I feel like, we neglected the whole manual therapy piece in our chronic pain patients because the world was telling us, don't put your hands on chronic pain patients. Like they'll be addicted to your hands. I'm like, no, you don't have to be so binary. Like we can still do manual therapy on our chronic pain patients, but we're addressing these other issues that we're talking about.
Yeah, and from a pain neuroscience perspective, I mean the phenomenology physiologically that we're talking about is central sensitization, and the evidence is quite good that often in that central sensitization phenomenology, there's a peripheral sensitization ongoing that's underexplored.
Right.
And if you and I aren't in our work trying to find that thing that is keeping the brain quite interested in that process and trying to down-regulate that, then we're not serving that patient as well as we could be. And, we can refer all day long and what we want, but you and I have seen pendulums, swing back and forth, Brett. We've been in this game long enough to see that. And the pendulum swung way too far in that, like it does with all of these things.
Right.
And, then everybody's like, well, it's all just in the brain. And it's like, please, guys, come on.
Yeah.
And then you have someone very nice, sound, and logical. I think his first name's Adrian Traeger, who did the lovely paper that Lorimer Mosley was a co-author on, where they were in Australia, what was this, maybe 2017, 2018. They were looking to try to crack that nut from a public health perspective of how to keep acute low back pain from progressing to chronic low back pain. And given that 90%, it's 80 to 90% of low back pain episodes resolve on their own and they don't become chronic, that would make you think that low back pain's not all that big of a deal, right? But that 20% makes up 90% of the healthcare expenditures for that particular condition. So if we can crack that nut on not going from acute to chronic, boom, we've got a really good thing. Well, what did they find out? They did an intervention of pain neuroscience education for patients with acute low back pain, and then they compared it to sham education, essentially a positive lifestyle, think good thoughts, go out, move a little bit more, blah, blah, blah. And there was absolutely no difference in outcomes on those two populations for that intervention. Does that mean the pain neuroscience is BS? Absolutely not. Is it all that? No. Is it every that? Possibly.
Right.
I would go that far. I would say that every patient that you and I see with back pain has a top-down component that we need to be aware of and potentially address. But that those top-down interventions, when we do them, probably we just need to be tangential to that intervention.
That's really well said. Yeah.
Yeah, because we talked about today, like if you're not willing to put your hands on your patients, they're going to find somebody that is. I mean, people are craving manual therapy, period. You know, and to think that you're just going to educate them and then everything's going to be great. No, they're going to go find it elsewhere. So why not be educated on both sides and have the ability to be a chameleon in those cases and to apply your manual therapy where it's needed through assessment and through history and other things like that.
Well, I mean, and back pain's very heterogeneous, as we all know. So so how do you separate, we all have been to the patient, you give them 10 press ups and it's literally a miracle. You take the exact same presentation, you give them 10 press ups and nothing, So, but you got to start somewhere, right? So it's like gambling all day, isn't it, Phil? Like you just statistically, you've seen this a couple different times. So you know that if I do this intervention, this is what I'm going to do. But sometimes that patient's in that 20%, so you need to know how to call the audible and do something different when 10 press-ups don't get them better, Do
you stop or you hold at 16?
You just keep going, damn it.
Do you hit it?
You need 4 more reps.
We need 4 more visits. Need 4 more visits for 10 reps.
That's right.
But I think that's where it's hard is people, they're going to jump, especially the younger generations, they're going to jump everywhere. You got to start somewhere, and then you got to just start it's almost like you're just checking things off, and you're not going to be right every time, and no one expects you to be right every time, but you also got to know when you're not right to know to do something different. And that's what I think sometimes the clinicians are not good at calling an audible and knowing we're not getting the desired outcome, or honestly, they punt too quickly to Western medicine when you still have, that patient just needs a little bit more of what you're doing, but you punt and then they end up getting an unnecessary procedure just simply because you didn't make the right decision, when things weren't going as well as they could have.
Sorry to interrupt this episode, guys. Hope you're enjoying it. Real quick, we have an amazing, amazing opportunity. The DNS World Congress is coming to Chesterfield, Missouri this June 14th through the 16th, 2024. If you guys attended our NDS or our Neurodynamics Congress, you know that this is something that's very close to Brett and I's heart, something that we are going to keep doing and keep doing and keep doing. So this year's Congress is all about DNS, dynamic neuromuscular stabilization. This is literally like looking into the ocean, as Brett says. This is the lens that we look through each and every one of our patients with. And this is going to be an amazing opportunity because Pavel is back in town. So the originator, the creator of DNS, Pavel Kolash, is coming to the States for the first time in 5 or 6 years. I don't even know how long it's been. He's bringing along with him Elena Kobasova, which is literally the backbone of DNS. She's one of the most underrated neurologists in the world. So we're super excited to hear from her. Marcela Safarova, if you haven't heard her speak, she is literally the queen of pediatrics and musculoskeletal health. We also are going to have almost every single U.S. instructor at the Congress who's going to be speaking. It's going to include demos, lectures, hands-on. We're going to have, as always, a get-together afterwards with your chance to talk to these guys face-to-face and have a couple drinks with them. This is going to be a great, great opportunity. It's a great price too, especially for students. It's only $4.99. So be sure to use the code DNS student to get your discount on that. For more information or if you have questions, go to gestaltedu.com/DNS-Congress. Thanks for tuning in, guys. Enjoy the rest of the episode.
Yeah, I think you really kind of nailed several lovely things right there. We've all been victim to it because it is developmentally appropriate when we're young practitioners that we look for the things that, we look for that extra edge, and we try to distinguish ourselves by going and doing the extra course, and then this course, and then this course. And we start to collect these courses and certifications like playing cards, And we're very similar from what I've observed over the years in this respect of taking the coursework, really trying to dive deep into coursework for any of these, 3-letter acronym silos
Systems,
that we like to play with. And then it's like you back out of it and you get out of the silo and it's like, all right, I can hear again, and I can see all of my patients again and see that, oh, maybe that one's not in that silo. What do I do? How do I mix this over here? And that was part of that My Rehab program when I was doing that, trying to put all these videos together of different systems so that a doc like you or me that's trying to integrate different systems to the N of one that's in front of us so that we could more easily integrate or put together some sort of a mixed integrated program for that patient that's right in front of us. And that's been the really fun aspect for the last 10 years of my practice and working with students and trying to see how we can keep them from being overly impressionable, appropriately coached and moved in their learning process, and not turn into some of the things that we were talking about off camera of the, how some of our wonderful, lovely mentors, people that are pioneers in this field, are regularly decimated in social media by, we will call them temporarily ignorant people. And that's a kind way of saying that they are impressionable, and developmentally so, and don't know it. But give them a few years, give them a few more patients, give them a little more time, and they will learn that. And hopefully, given the input of people that are a little longer in the tooth and have made the mistakes, that we can give them some information about how to integrate these things in a way that is effective in reducing the number of lost reps that they have in that process, and they can be better, and the people get served better, and healthcare costs reduce, and it's peace, love, and guitars.
Yeah, it's the best of both worlds, right?
I think the younger generation, I don't know why this is
you just said that,
but
damn.
Names that come to mind that sometimes I feel like people take unnecessary arrows. Mike Leahy's one, Stu McGill's another. If you don't think you can learn something from those two individuals, oh my Lord. Those two, there's other names that we could talk about.
There's a word for what you are in that case. You are wrong.
Exactly. Well, it's humble yourself to understand, and I just think that's, we were getting done with Mike Leahy one time, and so we're leaving, and I just point blank asked him, what do you think about all these snot-nosed kids who are, telling you that your mechanism's off and stuff like that? And he just, kind of like a savage, he goes, I'm going to work on 30 professional athletes down in Denver. He's like, maybe I'm wrong, but I know one thing, these athletes love what I'm doing to them. And I thought it was really well said. It's very, very succinct in that maybe my mechanism is wrong, I don't know, but all I know is these people are we're getting amazing results with this. And I think this younger generation, they're so quick to close the book on somebody. It's humble yourself and have a moment. You can learn something from anybody, and I feel I don't know what's happened as years have gone on that we've kind of lost the ability to do that well, but
Social media, bro.
Social media.
Well, I think it's healthy. We're all questioners. That's why we're hopefully decent clinicians, is we're questioning things all the time. And I think it's healthy to question mechanisms and things like that. Absolutely. But to question outcomes is kind of another thing. We can get more succinct on why things are working, the research backing it up and things like that. But as far as throwing the baby out with the bathwater,
yeah, come on.
Yeah, there's nothing in the world wrong with asking for peer-reviewed research to back up the findings that you're saying. I think that's a lovely trend, a lovely trajectory, and I think you also, all of us, ought to appreciate the inherent limitations of that system that we've all bought into.
Right.
That system is a good system. That system is science. That system is a reductionistic science. You mentioned before heterogeneous cohorts within low back pain. It's very difficult to parse that heterogeneity in research without getting reductionistic. And yet, you and I know that at the end of the day, there is magic in how you put the things together with the person that's in front of you. The thing over time, anticipating this talk today and talking about maybe the neurocentric approach stuff and all that which is my main thing that I'm playing with these days, how do I explain that? It's like having several good cooks out there. There is no best cook. There is no best chef out there. There are some damn good ones. Those chefs might have a specific cuisine that they are really passionate about cooking. Maybe it's all French. Maybe it's all Southeast Asian. Maybe they are just focused on what's local and what's fresh, and it's farm to table, and now you're in Portland. But those cooks have a way of figuring out how to put just the right amount of salt and just the right amount of spice and just the right amount of protein and just the right amount of fat and put all those things together under the right temperature, the right conditions, and oh boy, then the presentation. Can you put a narrative together that makes sense both to yourself and to the patient that's in front of you? Can you put it on a menu and put it on a table and make it look good, even if it's wrong?
Yeah.
I think
you can dress up shitty food
Yeah.
and make it look real good, and it'll still be an enjoyable experience.
Right.
And the patient will still go home. Yes. Yes. It's all the anchovies.
Yeah. Like in Talib's book, Black Swan, he talks about like the red herring. And I think like what happens when you're young is like you see one red herring, and then all of a sudden you're expecting 10 more red herrings. Well, you may go 10 years before you see that red herring again. Yeah. And
Beavers and horses.
Yeah, exactly. So I think like what happens with the younger clinician is they keep thinking about that outlier when really they can just go right back to what they were doing before. And then now you're better at recognizing the outlier. And when you gain more experience and you know what to do with that red herring, but I think that's like people get lost. Like they have that one case and they're like, yeah, well, don't derail everything that you know. Yeah. This is just like a once in a 10-year presentation, you know?
Yeah, that's a good way of putting it. There's I was having a conversation with one of my colleagues this weekend about red flags, yellow flags, and such, and they had in the last year 5 VBIs in their clinic. Okay, exactly. The first place, everyone who's listening, everyone here, the first thing that you think, what are you doing? Are you what kind of Okay, 1, it is a chiropractic clinic. 2, they are focused on MVAs. 3, every one of those cases, of all 5, none of them received spinal manipulation. None of them. Yeah. So another factor in all of this is the educational system, the way that we've set it up for all of us, is we have to pass board exams. And the board exams, one of the things that is the real onus on that process is to make sure that you don't miss red flags, and to make sure that you don't hurt other people that are coming into you for help. So if you are missing those things, that's bad. But blessedly, in the kind of practices that we all enjoy in physical medicine, most of those things get ruled out before they arrive in our office, but you still got to be able to pick them up. So I think it's appropriate to have appropriate level of vigilance, just in our, as we would educate our patients, to have an appropriate level of vigilance about certain feelings, certain little pings and nociceptive outputs that we have in our body, but not give them too much credence and not derail all of your training that you're referring to.
It happened to us in Vegas. Remember when we were playing? We married men have a little bit of a gambling problem, but so we go to.
So do you hit it 16 or not?
We're on the roulette wheel.
We're getting hammered in roulette. I mean, hammered. So hammered that the lady basically apologized to us, and she said, "I think we had like, I don't know how many."
It was 4 greens in a row, 4 zeros in a row.
What are the odds?
And she's like, "I've never seen this before."
It was
so
insane.
I mean, that sounds like the case that you're. So.
But it doesn't mean it's not going to happen. Just because
Right.
the odds are crazy.
Well,
doesn't
but
mean
then
it's not
after
gonna happen.
that, the regression to the mean, right?
Perfect. Well, we didn't really get into the neurocentric approach, and I'm purposely kind of leaving a little bit of things out there because I know that I'm craving,
We gotta get up his way,
I'm
though, yeah.
craving some Willamette Valley Pinots. So
Bring it.
But anyway, can you give just like a short kind of a promo for the neurocentric approach, 1, and then 2, what's the best place for people to find you in the courses you're teaching and kind of what you're preaching and stuff like that?
Let's see, in terms of the latter rather than the former, neurocentricapproach.com/events. That's where the in-person courses are. I've got if you go to neurocentricapproach.com, there are links there that link to the online academy, which quite honestly, call me old, call me crotchety. I'm not a big fan of social media these days. I am interested in finding people that are curious, that are willing to geek out with me about this process, pull them out of those medias. Let's go into almost a cloistered, intentionally cloistered community, and let's geek out together and let's grow the process. What is the process? What I'm trying to do there is integrate a variety of different systems and incorporate stuff that from several different venues that I've been very fascinated with for some time. One is mechanical sensitization of neurology. A lot of the work of Alf Brieg and Bob Elvey and David Butler and Lorimer Mosley and Michael Shacklock. That trend and appreciation of mechanical sensitivity and mechanical sensitization of the peripheral nervous system. The second is pain neuroscience education, how to learn it and talk about it in a way that is pragmatic and effective in patient care at our level of work in physical medicine. And the third is an area that, because of my own little personal issues and such, is longevity science and aging research and gerontology. And that has given us some windows into oxidative stress on the organism. You heard Andrew Hauser this weekend talking about some of those and the effects of it in athletes. On a more chronic level, in the patients that we see in our clinic, that starts to manifest as things that may cause increased sensitivity, mechanical sensitivity of neurology, and may cause increased central sensitivity. So now we're thinking about things like diabetes, we're talking about things like obesity, we're talking about lack of movement, lack of exercise, we're talking about too much willful self-poisoning.
Sleep.
Yes, sleep. These are places that we're trained in to ask our patients about, but all too often it seems those types of things wind up being just a very narrow point on the patient intake form that we really don't spend much time on. And I mean, if you're going to look at our practice, at our world in chiro and physical medicine and PT from a practice management standpoint, many of us have been taught to try to move beyond the idea of just hammering down high spots, rubbing out sore knots, and getting rid of pain. We want to improve function. We want to get a better rapport with the patient and try to develop some idea about who and what they want to be.
I think chiropractic set itself up to be
yes,
like that.
I think so too, Brett. And I will, as humbly as I can, with the ego that I've got and with the biases that I have, I think the neurocentric approach that I'm talking about could potentially be a reframing with more science of some of the classic ideas about nerve tone, neural tone, facilitated segments, and things that chiros have been talking about for, 125 years or more now. And I think this might be a way. I'm not willing to put on my Mandalorian hat yet. but it is.
Hear ye.
It's certainly a good cook way of making an omelet.
Love it.
Thank you, Phil.
You're welcome.
For your contributions to the profession, for physical medicine in general, and for sitting down with us. And we're going to get out there for some peanuts, because I'm telling you, I've got like the shakes, so I need it. But anyway, thank you for sitting down with us. Thank you for your contribution to R2P and things like that too. I think that's understated, but it's a great weekend. This podcast always get me going and make me think. So I appreciate you, Phil.
No worries.
Rock and roll. All right, guys. Well, good luck with patients, and we'll see you next time.
Rock and roll.
I hope you enjoyed this episode of the Gestalt Education Show. If you liked it, share it, subscribe to it, send it to your friends, send it to someone that needs to hear this message. We really want everyone to be able to tune in and get the best clinical advice that they can, which we're hoping that we're giving to you with these special guests. So if you have any questions, please feel free to reach out to us, or if you have any suggestions on upcoming conversations, let us know. For a list of our upcoming courses, we're adding them all the dang time. So go to gestaltedu.com, click on courses, and they'll all be right there for you. All right, have a good day.